87% of patients report that cancer treatment impacted their sexual function. Only 27% were ever asked about it.
Nobody talks to you about what it's going to feel like.
The doctors are dealing with your body, but I think, when it comes to your mind and your emotions, you also need, an expert to help you navigate all those big emotions.
During cancer treatment, it was like last thing that I want to do.
From a sex and intimacy perspective, you need somebody who's going to be supportive in that way because you are exploring something for the first time.
As a romance novelist, I would say we shouldn't forget our brains, which is the biggest erogenous zone in our bodies.
Yeah, my mantra is your body, your choice. You get to decide everything.
There is no bad question, except the question you don't feel comfortable asking. Cancer steals a lot of things, but one of the most isolating losses, the one that rarely gets discussed, certainly wasn't discussed in any oncology or integrated cancer office I went to, is what happens to your sex life and your sense of self as a sexual being during and after cancer treatment. Today, I'm doing something new. I've brought on 3 guests that are going to tackle what people don't talk about, how treatment changes your body, your desire, your relationship with intimacy, and what you can do about it. These are remarkable women who bring 3 different perspectives. Richelle Menzies is a clinical sexologist with a master's in sexology. She's also a breast cancer survivor and lived through, she'll talk about her year-long intimacy gulf between her and her partner. Now she helps others navigate these waters. Cara Lockwood returns to kicking cancer's ass. She's a USA Today best-selling romance author. She's made a career writing about healthy intimacy. She faced her own crisis when diagnosed with stage 1 HER2 positive breast cancer in 2023. She went through a double mastectomy, chemo, reconstruction, and wrote about it in her book, There's No Good Book for This. Erica Reith is a pharmacologist. She's a doctor, a PhD in pharmacology, and she's a trauma-informed life coach. She's also a breast cancer survivor, and she helps people move from surviving to living, bridging science of what's happening in your body with the soul work of reclaiming who you are after cancer changes your life. So if you or someone you love has wondered, will I ever feel like myself again? Will I ever want intimacy again? This episode is for you. Kicking Cancer's Ass brings you the stories, science, and strategies to maximize your power. I'm your host, Joelle Kaufman. Let's get into it. Richelle, let's start with you, with what nobody tells you when you get diagnosed. You spent a year, you said, without sex with your partner, and cuddling, you said, got difficult. And Cara, your husband was a big part of how you started to reimagine yourself. And Erica, you understand what's happening at the cellular level. So tell me, ladies, what did each of you not know about how cancer would change your intimate life? And what do you wish someone had told you the day you were diagnosed?
Great question, Joelle. I guess as a sexologist, I kind of understood what was going to happen physically. I'd already been through menopause, so I'd had that journey. But I guess it was more the psychological impact that I really, really struggled with. I found that I was okay with how my body looked. I had a double mastectomy to flat, and I'm now a flat advocate. And so, I'm out there swimming without my top on in the public and, doing all of those sorts of things. So for me, it wasn't about body image, but I know for a lot of other people it can be. But I talk about my sparkle, and I just felt like that went. It was like hormone blockers took my sparkle. So that cognitive side of it, that, the lack of desire, the feeling just fatigued, like all of the other side effects that go with it that make you just not want to feel like it, apart from the impact directly on desire. So, the hot flushes. Who wants to feel like having sex when you're all hot and sweaty? Who wants to feel like having sex when you're just exhausted all the time? There's so many different things that came into play, and I was aware of some of them, but I was definitely not prepared for how the emotional impact that it was going to have on me when those things started to happen. And it really shook me, because during menopause, I didn't feel like sex, but I still had sex. But during cancer treatment, it was like last thing that I want to do. Just forget about it. And that was a bit of a surprise to me because I saw myself as quite a sensual and sexual being.
I'll bet. The only thing my team told me about sex after I was diagnosed, and it wasn't something I discussed with my sister or my mother, even though they'd been through cancer treatment. They said, "Oh, you need to use condoms." And I've been married to the same man since 1998, so we have a monogamous relationship. I said, "Okay, who likes condoms? We haven't used them since we were, not married." But okay. So I mentioned this to my sister probably like 6 weeks in. And besides not having a lot of desire, the condoms really were not a positive for our sex life. And my sister said, "Why do they want you using condoms? Did you ask them if this is about pregnancy prevention or if there's actually risk from the chemo for your husband?" So Erica, you probably know the answer. But I asked. And they said, "Oh, no, it's pregnancy prevention." I'm like, I have no ovaries. If I get pregnant, it's the Messiah. So, Erica, what did you wish they told you?
Oh, man. I feel like the first couple of appointments, it's drinking from a fire hose. There's so much that you have to take in. And scientifically, I understood what was about to happen. I understood the chemo regimen I was about to be put on. I understood that chemo would throw me into menopause. I understood, that a hormone positive cancer would mean hormone therapy after. Nobody talks to you about what it's going to feel like. And I think that the biggest distinction I would make with, the appointments you have with your oncologist is most of them tend to be really hands-off when it comes to anything but the medical aspect of treating the cancer itself. My oncologist is fabulous. I love her. But she really wants to refer me away from her office for other needs. And so I really wish not so much that there was something somebody told me because I felt well enough informed about the process, but I would say that I wish that somebody had a better setup for getting you the supportive care from a sexual wellness institution, sexual wellness practitioners, or even just having your nurse coordinator set up some appointments with your OB so you can discuss pregnancy prevention if you're in that age range. Or you can discuss, with her what is about to happen. Because as someone in my age demographic, I was very premenopausal. And so, you hear all the things about what menopause is, and it's very different than the somatic experience of what it feels like. So I think that from a sex and intimacy aspect, I really wish that somebody would have just established the proper channels for me to be having those conversations earlier and for me to not have to have had to seek them out myself.
Totally makes sense. Did your team offer you Lupron, to protect your fertility?
Yeah, that was a question that I brought to my oncologist back in the day, and she at that point didn't feel like she had enough evidence for the benefit, so she opted not to put me on it. Turns out after the fact that perhaps there actually would have been benefit. So I did not have a Lupron-induced entrance into menopause. Mine was just, what the chemo does naturally. And I'm since on Lupron now, but no, not beforehand.
Yeah, my sister was actually part of the clinical trials for that in 2002, 2003. And for people who don't know, Erica, since you're a pharmacology PhD, what's Lupron and who should be asking their doctor about it?
Yes, absolutely. So if you are in premenopausal range and you are family planning or expect to be family planning and would hope to have children of your own someday after you've completed your treatment, then you should discuss with your oncologist the possibility of being put on there's 2 different drugs actually that do essentially the same thing. One is called Zoladex and one is called Lupron. And they both shut down your ovaries. And so they'll put you into what we consider ovarian suppression or medically induced menopause. And there's been some evidence that can show that there's potential for it to protect your ovaries and shield them from the chemo, because certain chemo regimens are known to be harsher on the reproductive system.
Yeah, and I'll put an end to that story for my sister. She had 2 children naturally post-treatment, post-Lupron. So, not a scientifically relevant count, but a good one. Cara, oh, sorry, did you want to say something, Erica?
Oh no, I was just going to say there's a lot of success stories that I've been hearing out there. So
yeah, and I think holding off or being able to return to a non-menopausal life is another benefit. So, Cara, what's your story? What'd you wish they told you?
Yeah, I think in general, I love what Erica was saying about like the fact that we don't get enough referrals to counselors who may tell us what to expect about how we feel about our bodies, and I think that was my experience as well. In general, I think the medical community as a whole tends to not pay attention to our feelings about our bodies as much as they should. I think when it comes to losing hair from chemo, or how you're going to feel about your reconstruction surgery or the lack of sensation, that's not really talked about in the doctor's office. They're more focused on, this is your recovery. This is the actual thing we're doing, but they don't talk as much about how you're going to feel about it. I think how you feel about your body, how you feel about the reconstruction, the whole process affects how you feel sexually. I mean, it's a direct tie. Like, how do I feel when I'm naked? How does my body feel? That loss of sensation has something, just personally for me, been much harder to deal with than I ever would have expected. And I didn't really get a heads up. I didn't really get a, hey, this might affect you personally in profound ways, and I think that's something that I had to discover on my own with my own counselor. And I'm very lucky to have had a fantastic counselor. And I think, honestly, it should be part of the regimen of everything, which is, the doctors are dealing with your body. But I think, when it comes to your mind and your emotions, you also need, an expert to help you navigate all those big emotions, including, sex drive and self-esteem and how you feel about your body. So I think that's just something that's sort of missing from traditional medicine, in my view.
Well, and I had a fabulous psycho-oncologist, and it was not something we ever talked about. Richelle, this one's coming to you, because according to research, 87% of patients report that cancer treatment impacted their sexual function, and only 27% were ever asked about it. How do you advocate for yourself when your oncologist isn't bringing this up and you don't have a sexologist on your Rolodex?
Yeah, it's a tough one, because I guess, if we think about it, all medical professionals are humans, and they all have their own, hang-ups when it comes to sex, and they're not really taught how to talk about it. And I think that there definitely needs to be sort of more education for medical professionals just about how to talk about it. And I guess I was very blessed. The reason I became a sexologist was our local cancer council many years ago, and I'm saying like 20 years ago, had someone talk to us as counsellors around how to talk about sex in the first 10 minutes when someone's been diagnosed. And it was as simple as, do you have any questions about how this might impact your sexuality or your sexual functioning? And I went, this is amazing. And it was many, many years later before I started studying, but I was blessed that my oncologist was very open. And I guess I'm kind of pushy, and I did find that I had to self-advocate, probably more with my surgeon, who was like very cut and dried. And even as a woman, she was like, when I told herself about my identity, she kind of rolled her eyes at me. And when I pushed the, aesthetic flat closure conversation, she also rolled her eyes at me. So you've got those attitudes that might come from some medical professionals, and then you've also got their lack of knowledge or comfortability about talking about it. And it is very unfortunate that sometimes we need to lead that conversation, which is not fair because we've got enough going on. But I was able to sit with my oncologist, who is an absolutely amazing woman, and just go, you know what, this isn't working for me. That's not working for me. This really sucks. And she was like, okay, what can we do? What can we do? And when that decision came for me to stop treatment, because I just felt like my life was one of actually not functioning in any area, and she'd had chronic fatigue from long COVID, she goes, I get it. But I guess sometimes it is that people who have had a similar experience, they get it. And if someone's not had any issues themselves with sexuality and sexual functioning and how you feel about your bodies, they often don't get it, do they? And
No, it's hard.
We don't often have the energy for that self-advocacy. And it's just one more thing to find exhausting. I find a lot of people jump online, and there are a couple of, sexuality and cancer, intimacy and cancer online groups, and people ask there. And the stories are often the same as I had to ask myself. Nobody told me, just as you've been saying, Joelle.
Well, I think there's an interesting conundrum, because I actually think the oncologists often don't really know. Like, they know what the side effects might be. And the surgeons, I mean, they should tell us all, you're going to lose sensation, because if you have a mastectomy, you're going to lose it because of the nerves that get cut. But I don't think they know what to say about, so now what? And Erica, you mentioned OB-GYNs. My OB-GYNs had no idea. They don't see that many cancer patients. They don't see that many people who are in early menopause. It was actually, she's a OB-GYN, but she's a survivorship specialist. That was the person who actually had the most information. But like you're saying, Richelle, I had to advocate and ask to get to her. And it's a fairly rare specialty. So what should we ask? And, do we ask the social worker? Do we ask our psycho-oncologist? Do we ask our OB-GYN? Do we ask our oncologist? Anyone can jump in here.
I think you ask everybody because you don't know who might have the information. So, ask your oncologist, ask your OB-GYN, ask your nurse. I think nurses are a font of information quite often. So just say, if you don't know, who can you refer me to? Because this is a conversation I need to have. And I think it's unfortunate that there's, with some people there are attitudes. There's been quite a bit of research done here in Australia, and quite often people talk about, just even general, about sexual issues when you're older. Oh, don't worry about that. You don't want that at your age, do you?
And the answer is?
Excuse me. And when have you decided that you're going to stop being a sexual being? And you can see them kind of go, they're not quite sure. So I think we need to ask everyone that we come in contact with until we find someone that's got the knowledge.
I think that's great. Now, obviously you can be a sexual being without a partner, but I'm pretty sure everybody on this call has or has had a partner and had somebody who was their intimate partner during their cancer treatment. How did you talk about it? Did you talk about it with your partner, and what was your partner's role in this? And Cara, I'm going to cold call you first.
Yes.
I know
Yes.
you have a story there.
Yes. We talk very openly about it. We have a very open relationship, and obviously I'm a romance novelist. So even, in my work, I'll, talk about a sex scene I'm having problems writing. Sex is something I'm comfortable talking about. And by the way, many, many, many older readers read romance. It is a prime demographic for us. So people are sexual beings for a very long time. There's no expiration date on it. So I think it was really about being honest and being authentic, even when some of those conversations were scary, because, I felt a lot of pressure after reconstruction, because so many people would be like, oh, well, now they're bigger, now they're perkier, now they're this and now they're that. Like, aren't you so excited that you have these? And quite frankly, I wasn't that excited. Like, it just was, they weren't mine. They still sort of felt alien, in that first go. I still had a lot of memory of pain, and the healing. And it just didn't feel like I wanted to, put on sexy lingerie and bounce around. It took a while. Like I think, my husband thankfully found me beautiful as I was and was just very thankful that I was healthy. And that was the most important thing for him. But he also saw that, I was just struggling with my own sense of self and my comfort level with my body. And let's face it, like I'm a woman in the world, so I was never 100% comfortable, with my body. I had flaws. But this one was just bigger than I was expecting. I just didn't expect that, that insecurity to pop up for things that weren't actually even mine.
Well, and it didn't sound like you were, there's this attitude of you're cured, you should be happy, you should be grateful. And I think we are. But you're changed, you're altered. And how you make space to grieve what you've lost, you can do both, grieve what you've lost and have gratitude for the fact that, you're here to breathe another breath and, hold a hand if that's what you're up for. But Erica, what about for you? How did you and your partner handle this?
Yeah. So I went through cancer treatments single. So there was, this aspect of anticipatory, well, what's it going to be like if I'm not really sexually active, during this process? How is it going to be when I get back into the swing of things, partnered? I think for me, there's a lot of aspects that go into a woman's sexuality that, are really heavily affected. Obviously, your breasts are changing, your body is changing. Your weight may fluctuate because of all of the treatments. Your hair, I was, basically wearing a half wig coming out of treatments. And, my approach to that was really just, this is a part of my story. This is a part of who I am. And it's okay if it's too much for someone. That doesn't mean that it's too much. It just means that, puzzle pieces aren't fitting. And so I got back out in the dating world. I told my, who became my partner on the first date, hey, I just finished treatments for breast cancer. I'm getting my life back. And he didn't bat an eye, So I think that women have this anticipatory, like, what's it going to be like to try to get back out there? There are good men out there there are good women out there are good people out there who aren't, going to be fazed by this. And so I think that from a sex and intimacy perspective, you need somebody who's, going to be supportive in that way, because you are exploring something for the first time. You're exploring what your body is like now, because it's not the same. Having your breasts be different, having your sex drive be different, having your ability to get ready and go be different. There's a lot of things where it takes a lot of patience and a lot of uncomfortable or comfortable conversations, and you have to be willing to have them. But I think that ultimately, whatever stage of life that you're in going into cancer, I think it's just going to require you to have so much patience and grace with yourself, because it's like discovering your sexuality for the first time. It's like whoever you were sexually before that, you cannot expect to return to exactly that person. It doesn't mean that you can't expect to get back to or get built up to this version that's good for you, but it just might look and feel different than before. So I had to give myself a lot of grace in that way, to just be willing to walk through with a new person, feeling like a new person in this new stage of life, and figure out what treatments work for helping me with the things I needed, what conversations we needed to have, and just take it one baby step at a time.
So first off, I applaud your courage. I think that, the conversations that Cara and Richelle and I had with our long-term partners have one level of risk and concern. You had to deal with a whole other level. And I just applaud your courage. I'm really glad to hear that there are good people who look beyond it and are willing to be on that adventure. But you mentioned something in there that I know was important for me. and I'd like you to continue. And Richelle, you may have something to say here, but your body operates differently post-treatment, particularly if you've done what I did, which was the crash into menopause. It sounds like that was Erica. And then Richelle got to do menopause twice, which sounds like a hell show. But, lubrication, vaginal atrophy, like these are things that are part of aging, but there is some better living through chemistry if you are willing to talk about it and ask for it. And I was wondering, Erica, if we could tap your expertise about what are the options for us, since, as Richelle said, we're going to be sexual beings even as we age.
Yes. Yes. Oh my gosh, there's so much on this. I talk to women about this all the time, literally all the time. I've made several videos on this. I think number one, the thing that, maybe isn't being talked about enough is if you don't use it, you lose it kind of analogy, which is just that the more you use your equipment, the better lubricated your equipment can be. The better the blood flow, the easier the time that your tissue has staying lubricated and the blood flowing to that area. Estrogen is the predominant hormone that controls our tissue frailty and our blood flow and our lubrication. And it also is kind of like the sensitizer to everything. So it also helps with oxytocin and serotonin. And so when you plummet and crash your ability to have estrogen in your body, not only do you have the physiological effects of the dryness, but you also have the psychological effects to where, your ability to feel connected and emotionally intimate and close is affected by the neurotransmitters that are being affected by the lack of estrogen. And let's not even talk about testosterone being the main form of libido and having that also crash out. In terms of options, use it as much as you can. Use it solo, use it partnered, use it however you can. That's going to help not only you reminding your body that it's safe, that you are still sexual, but it's also going to, anatomy wise, scientifically, it will help things. Number two, vaginal moisturizers. We've got hyaluronic acid suppositories, Replens, these, Reverie is another one. And those are a non-hormonal option. I don't give medical advice, but I've done a lot of research, and vaginal estrogen is
Safe.
a pro in my book. It's very much a pro in my book. I got on vaginal estrogen pretty quickly after I became partnered because I just realized I needed extra help in that category. Replenishing the moisture is not the only factor that estrogen affects. So vaginal estrogen is a conversation you can have with your oncologist if you are not currently on it and you're experiencing difficulty. And I went one step further personally to advocate for myself and put myself on testosterone because as a woman in my 30s who had a good libido prior to cancer, quality of life, as Richelle said, is very important. And you have to make those individual decisions for yourself with your care team. But testosterone is another thing that some women do opt for. It's potentially considered a little bit more controversial depending on your case and your risk factors. But my oncologist is pretty flexible depending on what I want to do. So she may have her opinions about whether there's risk or not, but she really cares about quality of life. So
those are great. And I think the message is like, there are options. You can explore those options. Don't DIY it on, drugs or, hormones. Talk to your doctor, but there
Yes.
are options. Now, Richelle, on the use it or lose it and being sexual, I want to give you the floor.
Sure. Look, I agree with everything that Erica has said, but when it comes to the use it or lose it, if there's pain and you use it, so if you have vaginal atrophy and you have pain, what you can do is you can set your body up to link any sexual contact with pain. So then you're on the road to vaginismus and a whole range of other issues. So there is that. If there's no pain, yes, keeps the blood flowing. It's fantastic. If there's pain, deal with the pain first. take penetration off the table while you deal with the pain. And I am such an advocate for vaginal estrogen. It was a lifesaver for me through my first lot of menopause. And the moment that research came out saying it's okay, I still had a tube because I had only been on treatment a year. So I still had a tube in the cupboard. I was straight back using it. I didn't even ask my oncologist. I was like, when I went in, I went, right, I've started using these and here's the research. And she's like, whoa, okay. She was quite conservative. She goes, oh, I need some more information. I went, well, I don't, because I had got to the point where even washing myself was painful. So externally, my clitoris had shrunk. I couldn't orgasm, even if I tried. Any touch was hell. And it was like it had progressed to that point where touching, washing myself and, just my clothes touching my vulva was awful. So I was like, I need to do something here. I cannot continue like this. So, I had a colleague that was even sitting. They had trouble sitting. It was so bad. So I started using that, and I'm just such an advocate for vaginal estrogen. And now there's more and more research being done, and more oncologists are starting to come on board. And my advice is, if you talk to your oncologist about it and they say no, take in the links to the research. It's easy to find, and to say, look, here it is. Lots of people are using it. And as I said to my oncologist, whenever I wanted to change something, when I wanted to stop treatment, I said, she's going, I went, I could just do it and not tell you. And she went, yeah, fair enough. Let's have the conversation. So testosterone, as Erica said, can be wonderful. I know that when my first menopause, it was a game changer. I felt so chronically fatigued for years and years and years. And I'd done my research, and I'd even spoken to the company that makes it here in Australia. We have one called Androfem, which is a testosterone cream for women. And it's quite expensive, but I was like, I think I need this. And eventually found someone who gave me a blood test and went, oh my goodness, your testosterone is 0. Let's put you on this cream. And within like a week, my energy levels had improved. It took about 3 months for the libido to kind of kick back in. So then with my cancer diagnosis, I had to stop everything just like that, I gave the estrogen a go first. And then I gave the testosterone a go. And I have found it hasn't worked as well for me this time around as it did previously. But I'm also a lot older. So, there's a whole range of other things that are probably going on as well. But for many, many, many women, they just say it's been such a game changer for them. Yeah, there are other medications now available. So there's Addyi and is it Valesi? I'm not quite sure how to pronounce them. We actually don't have access to them here in Australia, but they, some of them are just recently been TGA approved. Quite expensive. I think like $30 a pill. That's a lot. So hopefully something will happen and the prices will drop. There's kind of been mixed reactions, particularly when you look at the research. Some people are going, yes, that's great. Other people are going, I'm not sure. But the fact is that, female sexuality is finally on the agenda. Yeah. And it's been a long, long time. If it was men had low desire, there would have been something years ago.
There was.
So, Viagra is not for low desire. They need to actually have desire and have an erection, and Viagra just keeps the blood there. But desire is different. And
yeah, that's true.
And particularly when 75% of women have responsive desire and around about 25% of men do, there's so many things that will get in the way. And I think you're right, Erica. It's about finding out what this new you. And, one of the best resources I find is a book called A Better Normal. And it's like we talk about our new normal. What does that look like? And I know for me, it was a progressive decline over that first year of treatment. And, I started out with, where can I buy some sexy flat lingerie, and then as the pain started to increase, then, sexual contact of any type became less and less and less. And, the way to maintain intimacy was like naked cuddles. I found my scar lines incredibly sensitive, so that gentle touch on my scars was actually quite erotic, which was a surprise, and sometimes Our brain is an amazing tool that can rewire erogenous zones. And, I always love the story that Christopher Reeve's wife talked about. He was paralyzed from the neck down, but there was one spot on his shoulder that gave him intense pleasure, and that became his erogenous zone. And she said in an interview after his death, "You will often see me standing next to him with my hand on his shoulder." And it's like, the brain and the body can do such amazing things.
Absolutely.
And yeah, there is a lot more out there. There's still a lot more to learn, I think. And I think if you're struggling with your oncologist being on board or your gynecologist being on board, it's an easy Google to find the research, the peer-reviewed research, and take all the links and send them to them, or find yourself a new medical practitioner, one that's a little bit more open.
So I want to add a PSA here because you actually should use Google for that, or a search engine, like a health search engine, because the AIs, the LLMs, where a lot of people are doing it by chat, because women's sexuality appears to be programmed close to pornography, a lot of it they're suppressing. And so it can be harder to get data. Whereas, Google or WebMD or whatever else, will have the peer-reviewed papers. And maybe the LLMs will as well. I've been reading about how women's health is a problem on the LLMs. So Cara, let's hear your story.
Yeah, well, I actually wanted to talk a little too about, as we're talking about all of the prescriptions and the medicines that we can take. As a romance novelist, I would say we shouldn't forget our brains, which is the biggest erogenous zone in our bodies. So I think for me, it's part of what I do for a living. But I know that exploration of finding books or movies or video or other things that maybe gets you thinking about sex in a different way. You may even find a new kink that you have that you didn't know you had. Because I think giving yourself permission to search for that, to think about it, not just like, how is my body working, but how is my mind working? What is doing it for my mind? What fantasies do I, want to think about or, enact or do? There's so many options for us. And I think sometimes we feel ashamed, or sometimes we feel like we shouldn't give ourselves that gift, but it is a gift, so I think don't forget your brain. That's what I would say.
Well, and I think this concept of that Erica brought up of exploring, and I like the better normal, right? Like, there is something really fun about a sexual awakening when you were young. I mean, it was confusing and sometimes uncomfortable and embarrassing, but it's also exciting. And to some extent, we're forced into a second or third sexual exploration and awakening. And I found for my husband and I these like decks of cards that have discussion prompts or activity prompts that were a way of sparking intimacy and actually just changing the conversation. Like, the cancer conversation is just not sexy. And so I think that using your brain or inviting your partner to use your brain, to stimulate your brain, is a wonderful perspective with vaginal estrogen and maybe with testosterone. And, use it all. Use toys, use kink, use lingerie, use pillows.
Absolutely. Toys, everything.
Right.
Go for it.
Right. There's no rules here. We're consenting adults. But perhaps the reframe of this is going to be an opportunity of sexual exploration.
Yeah, absolutely. And I think it's an opportunity as well, especially either if you're in a new relationship or an older one. So like, re-explore that person, talk about things that you haven't talked about that might be turn-ons or turn-offs for you now that you've sort of have this new landscape that you're navigating. It's also a time to reset the rules. Maybe there's that thing you actually never liked. You can finally talk, now's the time. You could say, really, and especially now, I don't like that. but I really do like this other thing. I mean, it's the key to everything is good communication, and part of that is being honest with yourself too about what it is you like and what it is you don't like.
And I think Erica's point, notwithstanding Richelle about, not if it's painful, you've got to address the pain. But even if you're not necessarily like really gunned up to go be sexual, like you take a small step, try it, make appointment sex if that's what works, but, or appointment intimacy. It doesn't necessarily have to be penetrative sex, but try to have some way to connect because it is an important release. It's an important bonding and it makes you feel human and good. All right. Anyone want to add on that point before I go to a lightning round?
I think that particularly it is that there can be this shift, as I said before, about, spontaneous and responsive desire. And that for some people who had spontaneous desire before cancer, they now have responsive desire. And Emily Nagoski's book, I refer so many people to that. It's called Come As You Are, and it really unpacks what responsive desire is and gets you to think about what are the things. And she talks about brakes and accelerators. So what are your accelerators? What gets you going? But what are your brakes? What are the things that you suddenly that just kind of turn it off almost immediately? And what are the contexts where you are more sexual? And she kind of walks you through the whole thing. And it's really, really, really lovely journey. And I recommend that but the partners read it as well, so they have a bit of a better understanding. And I think definitely that experimentation and that the brain is definitely the biggest sex organ out, and that sometimes there can be a disconnect between the body and the brain that can happen with treatment. And there's some OTs, occupational therapists, who are now doing a lot of really good work in that sexuality and intimacy space and work around neuroplasticity. And that sometimes it is about removing penetration or anything that's uncomfortable off the table and exploring all of the bits of the body and what kind of touch in a safe way feels just nice, let alone sexy. Let's just start with pleasure. What is pleasurable touch? And eventually, it's like 10 minutes on each person and exploring the bodies. And I know I give a lot of my clients a little sheet that has parts of the body down one side and different ways to touch on along the other. And you either go, we're going to focus on one part of the body and try different touch, or we're going to try, one type of touch on lots of different parts of the body. And you have that communication, as you said, Cara, that feels really nice. Oh, no, that's a little bit uncomfortable. So you have that constant feedback and work out what feels good where. And as I said, sometimes you might have something that you went, I didn't know that light scratching of fingertips on the back of my knees was so pleasurable. So there's so much that you can learn about each other, and it keeps that touch going. It keeps the conversation going, and you do this progressively over about a 6-week period, and eventually starting with clothes on, then moving to clothes off, away from the genitals at the beginning, and then eventually kind of bringing in the genitals so that neuroplasticity has that time to work and rewire the brain back to linking the brain and the body, because there can be a real disconnect for some people.
This sounds, frankly, besides necessary, sounds kind of fun to explore in that structured and safe way. All right. I'm going to do rapid fire, which means just blurt out the first thing that comes to your mind. I'm going to call out your name for the person to answer. But if other people want to throw in an answer, say me too, and go ahead. All right. Cara, you're up first. Complete the sentence. The biggest myth about sex and cancer is
that that it's automatic, I guess. That it's automatic, that you're going to have sex even though you have cancer and it's going to be fine. But sometimes it isn't.
Anyone else want to answer that one? The biggest myth about sex and cancer is?
Sometimes it is that people won't even think about sex when they've got cancer. And that's a myth, because people do think about sex.
Love those both. All right, Erica.
I would say the biggest myth about sex and cancer is that it's one size fits all. Everybody has a different response to how cancer happens, and some people aren't going to be affected the same way. So don't assume that someone else's experience is going to be the way it's going to go, good or bad.
It's very wise. So, Erica, next one's going to start with you. From the nervous system perspective, what's one somatic practice that helps people feel safe enough in their bodies to even consider intimacy?
I think Richelle said it best. I was thinking about, the types of somatic exercises that would bring me back into my body. Because if I'm in a fight or flight response, then, intimacy is going to be off the table in survival mode. So as Richelle said, anything that is going to bring you back into your body, bring you to a place of at least neutrality, if not safety, when it comes to grounding, whether that's meditation, whether that's, the somatic mapping, name 5 things you can see, 4 things you can hear, feel, 3 things you can hear, 2 things you can smell, 1 thing you can taste. Anything that's going to bring you back into your body. Long breathing in and breathing out for longer than you inhale, tells your nervous system that you're safe. So
Smart. Richelle.
I definitely agree. I think I talk to a lot of clients about the 5 senses. So in that moment when you're with your partner, what can you see? Look in their eyes. What's their scent like? What does it feel like, your body touching each other? So that those 1,000,001 thoughts that are going through your head, going, this isn't going to work, and whatever it is that it's saying, that you're back in touch with your body. I just do have a slight caveat for that, because people who are neurodiverse, that can be really confronting. And one thing that sort of is coming to light is that through menopause, a lot of people are late diagnosed neurodiverse, their mask starts to drop. So the same thing can happen through cancer treatment. So that blocking of the hormones, the mask may start to drop for some people, and that realization that there's a whole heap of things they've been doing in their world that hasn't been working for them because they've been masking for so long. And that some of that sensory stuff can be a little more challenging for people who are neurodiverse. So just working out what is most comfortable for you as an individual.
So building on that, Richelle, what's the single most important conversation you think couples should have once they know it's cancer, but before they've started treatment?
Just what does this mean for our relationship? So what is this going to look like? Is this person going to be able to provide the support you need? And what does that look like? And I think, as Cara said, we need to work out what it is that we need and then communicate that to the other person. And I love a traffic light system: red, green, yellow. Get a piece of paper. Red are the things I definitely don't want. Green are the things that are my needs, I must have. Yellow are the these would be nice to have, but not absolutely essential. And once you've done that for yourself, then you can talk about it. It's a great negotiation tool. So think about, in my relationship, what does this look like? When it comes to sexuality, what does this look like? You can have 2 pieces of paper. What does this look like? So that then you've kind of got that, you've done that self-reflection, and then you can go into that communication. Otherwise, there'll be lots of, what do you think about this? Oh, I don't know, because you haven't had that time to sit and reflect.
Okay. Cara or Erica, anything you want to build on that?
Yeah. I mean, I think personally, cancer is the biggest stress test for a relationship. I think, it in all facets, from, sexual and physical to emotional support to, all of the levels of a relationship. And I think, communication is key. Personally, I love humor because I feel like that breaks down the barriers, whether that's in the bedroom or just, in the doctor's office. I think, finding a way to laugh together will bring you closer together. So, especially when talking about things are hard, sometimes my husband and I joke about things that are hard so that we can get at a core truth that maybe isn't like a serious, let's sit down and talk about this. We have a playful humor, but it says a lot of hard things sometimes.
I was so lucky and so willing to invite lots of people to support me that my husband actually said, "What's my job?" That led to a whole conversation about what could he only do, while lots of other people were doing wonderful things that were very supportive. But what was his role? And it was around intimacy and care and 3 o'clock in the morning. And so I think there's conversations about what do I need from you? What do you need from me? And I love the idea of using humor or the stoplight. And obviously, Erica, you did it on a date. Did you date people while you were going through treatment, or did you wait until treatment was over?
Yeah, I didn't really date. I focused pretty heavily on just treatment and getting well. I began dating afterwards, and I'd say in that case, survivorship, there's still a lot of factors, especially if you're on hormone therapy. You still are a person after cancer, and cancer is still a part of your life in certain ways, even in remission. And so I would say that the number one conversation there is just, you know, being curious about what that person's capacity is, letting them be curious because, some people don't have a great touch point to what is involved in that. And, you know, my partner had a lot of questions and curiosity about not only what would be different about being in a relationship with someone who's still going through, at the time I was still going through some treatments, and just rebuilding. And then also he was curious about what ways that he could support me. So very similar conversations to what would happen at the beginning, but I would just say a healthy dose of curiosity. And I think that everyone thinks that they need to have all of the answers immediately upon having these conversations, but I love to look at it as a weekly date to be like, how did this week go? Like, just assess as we go, and what needs to shift next week because that wasn't working well. What was going great? Let's keep doing that. Okay, I've realized that this need has come up and I didn't realize that I had it, or I didn't know to ask for it before, and just letting it be like a lower pressure situation where you can just figure it out as you go. Maybe it's the stoplight thing once a week. And does this stoplight still look correct to us? Do we need to add to it? Do we need to move anything? But curiosity always.
Excellent. And again, how wonderful it is to continue to be curious with your partner and to be continuously investing in your relationship. So, last question, and I ask this in every episode. So, I want your advice from each of you for someone who's looking to kick cancer's ass, specifically when it comes to reclaiming their intimate and sexual life.
Oh, I will. I will. I would tell you that cancer doesn't get to decide that you don't like sex anymore. That is not cancer's job. It doesn't get to take that from you. It's still in your control and your power. You can rediscover your sexual self at any time, and it's in your power, not cancer's.
Love that. Cancer doesn't get to decide your sexual anything.
I love that, Cara. And I'll also add medical professionals don't either.
I love that too. I love that too.
Yeah, my mantra is your body, your choice. You get to decide everything. If you want to have sex, if you don't want to have sex, if you want to reclaim and explore what does this new normal look like for you. If you want just to put a pause on things for a while, that's okay. You work out what's best for you, and you're the one that's leading this. Whether it's intimacy, it's what's happening with treatment, the conversations that you're going to have with anybody, your treating team, your partner, your family, your friends.
Amen. Erica, what's your advice?
I think mine always comes back to, and I guess this could be applied in the intimacy space of cancer treatment or just in general. I always like to remind people that, that their job is to commune with the part of themselves that still knows how to be well. It's really easy in cancer to focus on all the things that might be going wrong, that could be going better, the things that hurt, the things that are hard. But I like to have people imagine the best case scenario. Imagine yourself, a month from now, a year from now. Imagine yourself in the state of wellness that you want. Imagine yourself in the sex life that you want, and commune with that part of yourself because they're still there. They exist. You just have to continue to remind yourself that you have the ability to be well and work towards it and get the resources you need. But you can't commune with the problem and expect to make it go away.
Love that. So my advice, and I don't usually add, but there is no bad question except the question you don't feel comfortable asking. So ask questions, ask for what you need, ask for what you want, whether that is for your doctor, your nurses, your partner. Ask. Ladies, you have been a font of knowledge. You have been wonderful. Can you share where listeners can find out more about each of you? Richelle, you have a practice online?
I do. So my practice is called Sensual Potential. So people can find me on Facebook and through my website. So that's sensualpotential.com.au because I am in Australia. And they can find lots of information there, and also they can contact me that way as well.
Wonderful. Cara, tell us again about your book.
Yes. It's available on Amazon and other pretty much where you buy your books. And you can also find more information at Cara the author. That's Cara with a C, theauthor.com.
Excellent. And Erica, I know you're a coach as well. So how do they find you?
Yes, I just wanted to say thank you, Joelle. This has been a wonderful conversation, and I've enjoyed getting to speak with all of you today. Yes, I do offer coaching, and that can be found on ericareith.com. And I also do a lot of posting on TikTok and Instagram, and both of those handles are Erica Reith Coaching.
Super. And we'll put all those links in the show notes. You can find Crushing the Cancer Curveball also on Amazon. And I'm so glad we had this conversation. Your sex life is part of your life. Cancer doesn't get to change that. Cancer doesn't get to decide that. Cancer may have altered, but we all get to choose what comes next, what we want, and we all deserve pleasure. Thank you, guys.
Thank you so much.
Thank you.
Thanks, Joelle.